We have the last presentation, Dr. Nusbickel, and I love the title, Sick Heart.
Right. Hello, everyone. It's an honor to be here at the Houston Shock Symposium. I'm yet another internal medicine resident from the University of Florida. I'm presenting a case on behalf of one of our fellows, Dr. Prasada, who couldn't make it here today. And as was stated just now, this was a case of a patient who presented to our facility with a very sick heart and how we managed that. We have no disclosures for this case. So this is a 20-year-old female who presented to us with a history of asthma, substance abuse, methamphetamine, and a recent delivery. It was about 1 month prior to this presentation, was complicated by breech presentation, had a C-section, but otherwise no complications, and she was discharged home from that, seemingly at the time without any other issue. She presented to the RED via EMS for respiratory distress. She was actually intubated en route to our facility, and on arrival was noted to be in PEA, achieved ROSC after 2 rounds of CPR. Unfortunately, we don't have a strip from that event, but thankfully it was very brief. On physical exam after ROSC, she was noted to have bilateral lower extremity peripheral edema, bilateral bibasilar crackles, and her CT chest did not show any PE. Laboratory evaluation was notable for elevated troponins that peaked in the 8,000s, a lactate of 8.4, and a UDS that was amphetamine positive. And after this patient was initially stabilized, we were able to contact her mother, and she reported that since the patient was discharged from her recent birth, she had had several weeks of worsening lower extremity edema, shortness of breath, and orthopnea. So this is her EKG after ROSC, sinus tachycardia, some possible T-wave inversions in the precordial leads, but otherwise no obvious arrhythmia or ischemia that would have led to her, the presentation that we observed with her. Let's see if I can get this to play. So this is a TTE from the patient after her presentation. Unfortunately, it's not playing now, but it showed. It showed globally depressed LV function with ejection fraction estimated at 15 to 20%. And subsequent to this, the patient also developed worsening hypotension and decreased urine output. Let's see one last time. So the patient was taken to the cath lab. She had a right heart cath that showed numbers consistent with cardiogenic shock, had a cardiac output of 2.6 and a cardiac index of 1.5. Left heart cath was largely unremarkable, no coronary artery disease, no spontaneous coronary dissection or anything like that, and a balloon pump was placed during the procedure. There was a multidisciplinary meeting after she was in the cath lab, and the decision was that her iliac vessels were too small for Impella placement. Patient was about 5 feet tall and a little under 100 pounds, and VA ECMO was discussed as a bridge to recovery. So the decision was made in the setting of the patient's worsening hypotension and pressure requirements with the balloon pump to proceed with VA ECMO. The surgeons believed that her peripheral vessels were actually too small for peripheral ECMO, so she was taken to the OR for central VA ECMO. And following that, the patient's urine output increased, her lactate decreased over the following days. She was managed with myocardial rescue and ibuprofen. She had good neurological status throughout this time. She followed commands appropriately. And something that I would like to lead into our discussion for this case is that bromocriptine was initiated about 5 days after the patient was placed on VA ECMO. So I know this is a case of mechanical circulatory support, but I want to kind of guide our conversation into the medical therapy that was used in this case. And this is the patient's road to recovery. I wish it was playing because it's really remarkable. So the top left echo is EF of about 15% or 15 to 20%, and the final one, this is a series of TTEs. The final one in the bottom right, it was estimated at about 65%. So really a remarkable recovery over a period of a little over 1 week. So pretty substantial, and That's after the bromocriptine was initiated about at the time of the top right echo. So the patient was decannulated, the balloon pump was removed, and the pressors were briefly utilized during transition, but they were weaned shortly afterward. She was transferred to the cardiology service. She was on a different service, and we were following as consultants for an LVAD evaluation. But by that time, the patient's EF had fully recovered, her symptoms had improved, and she was not considered to be an LVAD candidate. She was discharged to home with follow-up in the heart failure clinic, in addition to addiction medicine follow-up. And she continues to follow there. This was about 6 months ago, NYHA class 1 symptoms as of her most recent visit, and her echo about 1 month after discharge was an EF that was within the normal range. So the kind of discussion that I'd like to have with this case is the use of bromocriptine in peripartum cardiomyopathy. This is currently a class 2B recommendation from the European Society of Cardiology. So not only expert recommendations, though not quite at the class A level. It has a very wide usage. So the lowest numbers I saw were 1% in the United States. I had personally not seen it at our facility, though I know there are facilities in the United States that have a higher rate of this. And the highest rate that I saw was 67% in Germany. I know there's a few people here from Europe today. If one of them would like to remark on kind of how this is used in their facility, I'd be really happy to hear that. The theory behind the pathophysiology of bromocriptine in peripartum cardiomyopathy is that this is a central dopamine agonist. I think a lot of us might have studied this during our endocrine unit in medical school. But one of the theories for peripartum cardiomyopathy is that a prolactin cleavage product has effects on the myocardium that lead to peripartum cardiomyopathy. This is, in addition to the hemodynamic changes of pregnancy, such as the increased blood flow to the uterus and the increased volume. And literature has demonstrated good LVEF recovery and symptomatic recovery with bromocriptine and peripartum cardiomyopathy. There is a study that's starting, I believe, just this year in the United States and Canada, the Rebirth study, randomized evaluation of bromocriptine and myocardial recovery therapy. That's going to be following a group of 200 patients in peripartum cardiomyopathy and a control group of 50 patients who are not taking bromocriptine with peripartum cardiomyopathy. Those patients, because one of the effects of bromocriptine is that it inhibits lactation, so there's a ready control group that would prefer not to take this regardless of the other effects. So thank you all for your time. And
Thank you very much.
So I thought that was a great case. I think you did a great job presenting it. Did you get an MRI on this patient or anything after that? Because the issue is this diagnosis really postpartum cardiomyopathy? Was this a post-arrest stunned heart that recovered very quickly? Could this have been a subtle myocarditis that caused an arrhythmia that led to it? So it's just, we're not sure it's true and related. So I just think that I would have done a little bit more to be sure that I knew exactly what the inciting agent was. You've got Bicam here, so I'll look forward to
yes, I do agree. So there are several nuances here. The rapidity by which she immediately improved, which is the reversibility in peripartum cardiomyopathy is 50 to 60%. But usually we see it in days to weeks, not rapidly within the same hospital setting, which then creates the question of the hemodynamic status pre-event. Whether she did have a preeclamptic, amphetamines on board and an insult to the myocardium to create that stunning along with the arrest, and thus creating that immediate unloading, creating an immediate recovery on the ventricle. But back to the concept of the chicken egg, what was the cause of her initial concept? Was it maybe a more of an accelerated pattern of a peripartum with the amphetamines? I think is a good question. Now, the prolactin story is, as you stated, is at an equipoise because the studies that supported or demonstrated a benefit on EF were rather small-scale studies, and thus requiring a randomized clinical trial in a multi-center manner that is being initiated with NHLBI Sport, which is the Rebirth trial. That's going to provide us, because prolactin antagonism is not without risk either. So in essence, currently right now, I'm not so sure that's the agent that resulted in immediate recovery within 5 days of a hospitalization. because that signaling probably would not be able to create that much of a hemodynamic effect right away through the prolactin pathway. So I consider that also almost like a placebo effect. But the unloading, elimination of whatever the insult was probably is what played a role. Whether this was a peripartum cardiomyopathy, possibly. Yes, there are so many different features of peripartum cardiomyopathies. But again, the rapidity by which it resolved creates a question about whether this was a hemodynamic insult. And amphetamines, different patterns of amphetamine-induced myocarditis, acute myocardial injury, and chronic cardiomyopathy. If the ventricle is fibrosed with chronic use, the recovery is not that rapid. But if acute dose-related, that they sometimes present this with this acute amphetamine toxicity, that is usually reversible too. I think this patient may have had both of those.
Ali. Ali.
I think it's a great job. The patient survived. She requires the mechanical circulatory support. We can discuss about the etiology. That's true. We have to look for that. Probably biopsy could help as well. But regarding bromocriptine, I think we were using that and used that in Germany before I came to the United States. But we're guiding our therapy with the prolactin level. We do that before starting with the therapy. And we guide our therapy in such kind of cases, and we use that in patient on ECMO or mechanical circulatory support with peripartum cardiomyopathy. It's not, we didn't use that in a randomized trial, but it's part from our what we're doing here. And I think there is a study from South Africa was published. I don't remember where we used that in a randomized study and showed survival.
It was randomized small scale, and both studies are from South Africa. From CARE.
I don't think that was a placebo. I'm just going to say, evaporating. Congratulations. I don't know if Dr. Westerman's in the audience, or maybe they left our German colleagues. From Jena, they're doing a randomized study. I don't know if it's going to be published with Christian Schulze. Evaporating on ECMO. I've tried to use it at Jefferson. I'm kind of pushing to get it on formulary to try to get experience with it. I think it's brilliant. That could have been a huge determining factor. And maybe you can go back and look in the chart and see how much of a rate response you had with patient on ECMO. These patients don't need a heart rate of anything on ECMO. And if their heart rate is 100, not anything. You can't be bradycardic, but probably.
Titratability, how are you going to do how much is too much, how much is too little?
Became proof of concept first, is what I would say. Because the Jena group is randomizing, and I congratulate Christian. I hope they finished their study. I think it's what we're taught by Emma Burks. The recovery teams know that you cannot leave a heart rate, especially when the RV is involved, up too quickly. And we've had great success trying to get the heart rate down through many mechanisms. Use vaso instead of Levophed. That's what we're talking about as well with respect to other, formulations of pharmacologic support afterwards. But I can't wait for the Jena data, but see if the heart rate made a difference. See if it even impacted, because to her point, maybe you don't impact it too much with evaporating, but I would love to see that.
Yeah, she was tachycardic while on ECMO, and they initiated beta blockade, and then after that, evaporating, and it did decrease after that. I think which was the etiology of that, it's hard to tell, but it did decrease after her.
My gut feeling is bromocriptine may be a positive trial. It may be small, but evaporating is going to be a huge, hopefully, lift for us in recovery on ECMO. Tell Christian that.
I have a point. I think cardio-obstructive critical care is in its infancy.
Yep.
And I think America, with our maternal mortality rates, it's really embarrassing. And this woman made it because she made it to you guys at UF.
Yep.
And our patients make it. We are we have a center. We're trying to pull all the resources together. But I'm dismayed for a large portion of America that has no access to shock centers.
And things are going in the adverse direction. The mortality rate for maternal death is rising in the United States, and due to a variety, but predominantly is cardiovascular death, predominantly uncontrolled hypertension, and predominantly not having access to care. So yes,
Bikram, is it still southern? Is there kind of a stroke belt equivalent?
Correct.
Oh, that's
absolutely.
sad.
Poor access, poor care, poor follow-up, poor maternal care are the related factors and disparities. But the worrisome thing is it's cardiovascular. It's not just septic and emboli and so forth and post-operative problems. It is cardiovascular, and it is rising, and it is resulting in increased mortality rates in women.
Can I add to that, that in the southern belt you have diastolic heart failure.
Right.
Women come in, there may be some drug abuse in some of them, and I feel like that connection to the patient is not there. So there's a huge healthcare disparities in this. So I urge all the cardiologists or whoever else is in this room that are passionate about this to go into this. This is an unmet need.
If you believe it's peripartum, I agree with them that probably this is not peripartum. Yeah. If it is peripartum, what are you doing with the next pregnancy? Because she'll be here 6 weeks later in your same university with the same problem.
Right.
First, get the amphetamine out.
One more last question, please.
Just a comment, and you did a beautiful job presenting a complex case. We have an extensive cardio-obstructive program at Minneapolis Heart, and the nature of the discussions and the collaboration and the support team brought around these patients, very challenging patients who have arrhythmias, valvular heart disease, they may have amniotic fluid embolization. There's many, many things that happen. And the quality of the conversation when they're siloed over on the cardiac ward is very different when it's collaboratively approached within a mother-baby center. And this is the way of the future. But for those of you who don't have experience with it, please engage it, because it's one of the most rewarding areas to exercise physicianship and medical skill and develop communication skills, and certainly meeting an unmet need.
It should be the standard of care.
It should
Fully
be.
agree.
Yeah.
Thank you very much. The really last question now.
Yeah, no, I just wanted to make a comment. At Jefferson, we've started a multidisciplinary cardio-obstetrics clinic where the OB, the MFM, and the cardiologist, we see the patients for preconception counseling, and also the high-risk pregnancies are seen in this clinic and in the same place, in the same location. And we've had a huge success in just, discussing contraception during their pregnancy, so that they have a plan. We make a plan for labor delivery, conception, contraception post. So we've had a huge success caring for these patients, and also extended postpartum follow-up beyond the 6 weeks that is, standard. So we transition these patients to the cardiology clinic. Like I see these patients for a long term, especially preeclampsia is just becoming a huge problem. So I think it's important for this multidisciplinary collaboration. And it's very rewarding, like you said.
One comment I'm going to make, once we establish these, we need to make it hub and spoke, because we will not have adequate specialists for us to be able to, so we will need to then tie with the primary care and OB and make it as such it's going to be like the adult congenital, because there won't be adequate number of cardiologists to touch on every obstetric case, but we'll need to do a hub and spoke.
Thank you very much.